Imagine you're expecting a baby, or maybe you're a new parent, and boom, this frustrating skin thing pops up. Could be stubborn acne, maybe some itchy eczema, or even an infection. You reach for that cream you always use, but then you stop and you ask yourself, wait, is this actually safe for my baby?
Hmm.
It's a really common moment of doubt, right? And finding good, reliable info can feel, well, overwhelming.
Totally overwhelming. There's so much noise out there.
Exactly. So today we're doing a deep dive into that specific world. Topical skin treatments,
Mm.
the creams, the gels during pregnancy and when you're breastfeeding. Our mission, to unpack a really thorough clinician-focused review. We want to sift through what's generally okay, what you really need to steer clear of, and importantly, where the science is still kind of catching up.
Think of it as a shortcut, maybe, to get the key takeaways.
Yeah, a shortcut to feeling more informed and confident about treating skin conditions safely during these really critical times.
And it's interesting, the context here is how the guidance itself has changed over the years.
How so?
Well, a big shift was the FDA's pregnancy and lactation labeling rule, the PLLR. That moved us away from those old letter categories. Remember the ABCX stuff?
Oh yeah, vaguely. They always seemed a bit confusing. C was always the big question mark.
Exactly. That's a great point. C could mean so many different things. Maybe no human data, just some animal studies, or maybe limited human data, but nothing obviously bad. It just wasn't very helpful.
Caused a lot of anxiety, I bet.
It really did. People sometimes avoided treatments they actually needed. The new system uses narrative summaries. It's much more detailed. It basically forces a better conversation about the actual evidence or sometimes the lack of evidence.
So it moves beyond just a simple label.
Precisely. It empowers you and your doctor to look at the nuances and make a truly informed decision together. It's a much better approach.
That makes a lot of sense. A much clearer picture. Okay, so before we jump into specific treatments, just our standard but really important reminder. This is all for educational purposes. It's not personal medical advice. Always, always talk to your own doctor or healthcare provider for advice specific to you.
Absolutely critical.
All right, let's get into it. Before we talk about, say, acne creams or eczema treatments specifically, are there some golden rules, overarching principles for using any topical medication when pregnant or breastfeeding? What's the basic advice?
Yes, there definitely are some really clear foundational guidelines. The absolute core idea is you want to prefer things that have negligible systemic absorption.
Meaning stuff that doesn't really get into your bloodstream much.
Exactly. Stuff that mostly stays on the skin.
Yeah.
And ideally, products with a long track record of safe use. We like things we know well. Beyond that, it's all about minimizing exposure. So treat the smallest possible area of skin.
Right.
Use it for the shortest time needed to get the job done. And always use the lowest strength, the lowest potency. That's still effective for you. And a really key one, avoid occlusion.
Occlusion, like wrapping it in plastic wrap.
Yeah, or tight bandages over it. That can dramatically increase how much gets absorbed. So definitely avoid that unless specifically told otherwise by your doctor.
Got it. Smallest area, shortest time, lowest strength, no wrapping.
You got it. And then if we think specifically about breastfeeding, there are a couple more practical things. You absolutely want to avoid putting any product right on the nipple or the areola.
To avoid the baby ingesting it directly.
Precisely. If you absolutely have to use the topical on the breast itself, like for mastitis or something, it needs to be wiped off completely, cleaned thoroughly before you feed the baby.
Makes sense.
And if it works with your schedule, try applying it right after a feed.
So it has maximum time to absorb before the next feeding.
Exactly. Gives it a bit more time, further minimizing any potential exposure.
So it's not just what you use, but really how you use it. Being super mindful.
Absolutely. Even for something generally considered safe, if you slathered it everywhere or used it under occlusion, well, you could potentially increase that systemic absorption.
Right.
So those rules, smallest area, shortest time, lowest potency, they really apply across the board. Minimize that chance of anything reaching the baby unless it's truly necessary and cleared by a doctor.
That's a really helpful framework. Okay, building on that, let's talk specifics. A super common one, topical corticosteroids. For things like eczema, dermatitis, what's the latest thinking on those during pregnancy and lactation? Are they generally okay, or is there still a lot of caution?
Yeah, this is a big one because they're used so widely. For pregnancy, the good news is we have a lot of data. We're talking large reviews, like a Cochrane review looking at 1.6 million pregnancies, a big Danish study.
Oh, okay.
And they generally show no overall increased risk for things like birth defects, preterm birth, or the baby being born small. That's quite
That
reassuring.
is reassuring.
However, there is a little signal, a possible link, for low birth weight if someone uses large amounts of the potent or very potent steroid creams over a long time.
Ah, so the strength matters.
It really does. Which brings us right back to those golden rules. Use the lowest effective potency you can get away with, smallest body surface area, shortest time, avoid occlusion. For breastfeeding, they're generally considered compatible. Any strength is usually okay on skin away from the breast.
But if it's on or near the breast?
Wipe it off completely before nursing, every single time.
Okay, so generally fine, but be smart about it, especially with the stronger ones. Now, let's shift to another area where, honestly, I think people get really confused. Acne and rosacea treatments.
Huh.
Super common, right?
Right.
But there seems to be so much conflicting advice out there, especially when pregnancy comes into play. What's the deal?
You are so right. This is a category where clarity is just essential, and misinformation is unfortunately pretty common. A big misconception is thinking all acne treatments are forbidden. That's just not true.
Okay, good to know.
This review really helps clarify. So, things that are clearly acceptable, good to go in both pregnancy and lactation. Benzoyl peroxide. Very little gets into the system.
Correct.
Azelaic acid is another good one. Topical antibiotics like clindamycin or erythromycin are fine. And for rosacea, topical metronidazole is acceptable.
What about salicylic acid? That's in a lot of over-the-counter stuff.
Right. Salicylic acid is one where you need a bit more caution. It can be used, but generally only on small areas for a short time. Not really a first choice during pregnancy if other options work. Now, the really critical part, the avoid strictly list for pregnancy.
Okay, wean in for this one.
All topical retinoids. That means tazarotene, trifarotene, adapalene, yes, even adapalene and tretinoin.
All of them.
All of them. It's a class concern. There's known or theoretical risk.
Yeah.
And tazarotene is specifically listed as contraindicated. Just avoid them entirely during pregnancy.
That's a huge takeaway. No topical retinoids during pregnancy.
Huge takeaway. For lactation, things like benzoyl peroxide, azelaic acid, those topical antibiotics are generally compatible, but you still want to make sure the baby's skin doesn't come into contact with the treated areas.
Makes sense. Avoid direct transfer.
Exactly. So the bottom line is retinoids out for pregnancy, but you definitely still have other effective options.
That is crystal clear, thank you. Okay, moving on. What about other common concerns like, say, hair loss or maybe hyperpigmentation, those dark spots? Are treatments like minoxidil for hair or hydroquinone for lightening spots safe?
Good questions. Minoxidil, often used for hair thinning, should generally be avoided in pregnancy. There are some case reports suggesting it could cause excess hair growth on the fetus, fetal hypertrichosis, and we know some of it can get absorbed systemically.
Okay, so avoid.
Yeah. And in lactation, caution is advised and definitely keep it off the breast area. Hydroquinone, used for skin lightening, is another one to avoid during pregnancy.
Why that one?
It actually has pretty high absorption through the skin, maybe 35% to 45%. That's quite a bit.
Wow.
So because of that significant absorption, the recommendation is to avoid it during pregnancy. Any cosmetic lightening is probably best put off until after the baby arrives.
Okay, and what about clascoterone? That's a newer anti-androgen for acne, I think.
Right. For clascoterone, there's basically no human pregnancy data yet. So regulators advise against using it in pregnancy. During lactation, it's a risk-benefit discussion with your doctor, and again, absolutely avoid applying it to the breast.
Seems like a pattern here. If it gets absorbed easily, be extra careful or just avoid it.
That's a very good rule of thumb, absolutely.
Okay, let's touch briefly on infections. Sometimes things pop up, fungal infections, bacterial ones, maybe a cold sore. What about topicals for those? Antifungals, antibacterials, antivirals?
Yeah, generally for many common infections, the topicals are okay because, again, minimal systemic absorption. For fungal stuff like athlete's foot or yeast infections, the common topical imidazoles, clotrimazole, miconazole, and nystatin are first-line choices and acceptable in pregnancy. Topical terbinafine also seems okay.
And for breastfeeding?
Same applies. Generally acceptable. Just remember the rule. Avoid the nipple area. One quick note. For fungal nail infections, the lacquers like cyclopirox or efinaconazole, we have very limited human data. So if it's possible, waiting until postpartum to treat nail fungus is often the preferred route.
Okay, that makes sense. Defer if you can.
Right. For bacterial things, mupirocin, fusidic acid, topical clindamycin, erythromycin, metronidazole, those are all generally acceptable in both pregnancy and lactation. Low absorption.
Good.
Antivirals like a cyclover or penciclover cream for cold sores or genital herpes, also acceptable. Very tiny amount gets absorbed systemically.
Okay. And lastly, antiparasitics, like for scabies or lice.
Permethrin 5% cream and pyrethrins are the first-line treatments. They are considered safe in pregnancy and compatible with lactation. The one to strictly avoid here is lindane. Definitely no lindane.
Okay, good to know. Permethrin, yes. Lindane, no. So it sounds like for a lot of the older, well-known topicals that don't get absorbed much, things are generally okay with those key precautions.
That's a fair summary, yes.
But what about more specialized conditions, like psoriasis, or maybe some of the newer non-steroidal creams people are hearing about? This is where it gets trickier, right? Less data.
Absolutely. This is where you really start balancing the need for treatment against often limited human safety information. For psoriasis, take vitamin D analogs like calcipotriene. There's limited human pregnancy data, so the advice is use only if necessary, keep it to small areas of skin.
And lactation.
Acceptable on small areas, but again, absolutely not on the breast.
What about older things like tar preparations or anthralin?
Yeah, tar and anthralin, also called dithernol, are generally avoided during pregnancy. There's limited safety data, and usually there are other alternatives. They're probably okay on limited spots away from the breast during lactation, but again, caution is needed.
Okay. Sticking with specialized treatments, what about for warts? They can be stubborn, or those field therapies for actinic keratosis, the precancerous spots. Are there definite no-goes there?
Yes, absolutely. Some really strict contraindications in this area. During pregnancy, you must strictly avoid podophyllin resin and podophylox. Also topical 5-fluorouracil or 5-FU. These are strongly discouraged due to potential harm to the fetus.
Okay, podophyllin, podophylox, 5-FU, hard no in pregnancy.
Hard no. For imiquimod, another common one, there's limited pregnancy data. Most guidelines say avoid it unless there are really no other options.
So what can be used for warts in pregnancy?
Things done in the clinic, like cryotherapy, freezing it off, or applying trichloroacetic acid, TCA, those are generally preferred and considered safer.
I see. And for lactation?
Imiquimod is probably low risk if you use it away from the breast, but you still need to avoid podophyllin, podophylax, and 5-FU during lactation as well.
Good to have those clear boundaries. Okay, itching, pruritus, so common, especially in pregnancy. What about topical antihistamines or numbing creams, anesthetics?
Right, itching can be miserable. There's one topical antihistamine cream, Doxtin 5% cream, that needs a big warning label.
Oh, what's the issue?
It should be strictly avoided during lactation. There are reports of it causing sedation, drowsiness, even apnea pauses in breathing in infants whose mothers used it.
Wow, okay, that's serious. Avoid Doxtin cream while breastfeeding.
Definitely. And generally avoid it during pregnancy, too, unless there's absolutely nothing else.
What about lidocaine, like for numbing?
Lidocaine, whether it's a topical cream or an injection like you get at the dentist, is generally acceptable in pregnancy and compatible with lactation. But, and this is crucial, you must never apply any anesthetic cream to the nipple or areola.
Why not?
The baby could ingest it while feeding, numb their mouth and throat, and potentially interfere with swallowing or breathing. It's dangerous.
Okay, never on the nipple. Got it. What about EMLA cream? That's a mix of lidocaine and prilocaine.
EMLA also needs caution. There is a rare risk called methemoglobinemia if an infant gets excessive exposure. That affects how blood carries oxygen.
Also sounds serious.
It is. So again, the rule is avoid infant exposure, never on the nipples.
That's a really critical warning about doxepin and keeping anesthetics away from the nipple area. Key points there.
Absolutely key.
Okay, now let's get to the really cutting-edge stuff. These newer non-steroidal immunomodulators. We hear names like crisaborole, roflumilast, tapinarof, ruxolitinib cream. This is where things get interesting, right? Newer drugs often mean less long-term safety data, especially in pregnant or breastfeeding women.
Exactly. This is where we hit significant evidence gaps. It's the frontier, in a way. Crisaborole, that's a PDE4 inhibitor mainly for eczema. It actually has very low systemic absorption, which is good. The labels say no human pregnancy data, but there isn't a specific contraindication. So it might be considered a reasonable steroid-sparing option sometimes.
And lactation.
Low expected transfer into milk, but still the advice is avoid the nipple. However, for the others you mentioned, roflumilast, tapinarof, ruxolitinib cream, we really have very little human pregnancy or lactation data at all.
So mostly unknowns.
Pretty much. Animal studies for these do show the drug or its byproducts getting into milk. So the general guidance for these newer agents is cautious. Use only if the benefit really outweighs the potential unknown risk. Prefer the older, better studied options first.
Hmm.
And for lactation, definitely avoid the breast area or only use strictly off breast after a detailed discussion with your doctor, especially if other treatments haven't worked. It really highlights the challenge we get exciting new drugs, but proving their safety in pregnancy and lactation takes time.
That really drives home the importance of that shared decision-making with your doctor,
Yeah.
especially with newer meds. Okay, let's shift slightly to things we might use almost daily. Sunscreens, big topic. Chemical versus mineral filters. What's the actual recommendation during pregnancy and lactation?
Yeah, sunscreen is essential. The bottom line up front.
Hmm.
Any broad spectrum SPF 30 or higher sunscreen is way better than nothing. We need sun protection.
Right.
But if you have concerns or just want to be extra cautious, mineral filters, zinc oxide, and titanium dioxide are often preferred.
Why is that?
Because they work by sitting on top of the skin, creating a physical barrier, they aren't really absorbed systemically. Some studies, those FDA maximal use trials, showed that several organic or chemical filters can be absorbed into the bloodstream.
Ah,
Now, that hasn't proven harm, but it has led to calls for more safety data. So, for peace of mind, many people opt for mineral sunscreens during pregnancy and breastfeeding. They're also recommended for sensitive skin and for infants over 6 months old.
mineral preferred for extra caution, but any SPF 30 plus is better than none. Got it.
Yeah.
And the simplest things. Basic moisturizers, barrier creams like petroleum jelly, colloidal oatmeal for dry skin. Any issues there?
Generally, no. Emollients, petrolatum, glycerin, colloidal oatmeal, these are all completely acceptable, totally fine during pregnancy and lactation.
Sure.
The only caveat is the same one we've mentioned. If you apply them to the breast area, just wipe them off thoroughly before feeding the baby to avoid ingestion. Simple precaution.
Okay, even for basic moisturizers, wipe off the breast before feeding.
Mm-hmm.
So let's try and pull this all together for everyone listening. What are the absolute must-avoids, the hard stops, and those really key practical tips for breastfeeding?
Okay, let's recap the big ones. For pregnancy, the strictly avoid list is all topical retinoids, tazarotene, trifluferetine, tretinoin, adapalene,
Got it.
podophyllin and podophylax,
Right.
topical 5-fluorosyl,
Mm-hmm.
hydroquinone because of that high absorption,
Yes.
and topical minoxidil. Those are the main no-goes in pregnancy. For lactation, the key practical points are most topicals with low systemic absorption are likely compatible if used away from the breast.
Okay.
If you must apply to the breast, do it right after nursing, clean it off completely before the next feed, and avoid things designed for slow release or used under occlusion on the breast. The main topical to strictly avoid in lactation is that doxepin cream because of the risk of infant sedation or apnea.
Critical warning there.
And always, always avoid getting topical anesthetics on the nipple area where the baby could ingest them.
Fantastic summary. Really clear do's and definite don'ts. So we've covered a huge amount of ground today, from your everyday corticosteroids and acne stuff right through to specialized psoriasis treatments and these newer immunomodulators. We've pinpointed the clear yeses and nos, highlighted where you need that extra caution, and importantly, where the science is still developing.
It's a complex landscape for sure.
It is. Our real hope with this deep dive is that you feel more empowered now, with a clearer understanding of how to navigate skin conditions safely during pregnancy and lactation. It really boils down to making informed choices, doesn't it? For your health and for your baby's well-being, turning that doubt into informed action.
Absolutely. And that actually leads perfectly into a final thought to leave you with.
Oh,
Yeah, thinking about the future. Given how quickly new drugs are being developed and seeing these persistent gaps in evidence, especially for newer topicals in pregnancy and lactation, how can we, as informed patients, as advocates, push for more comprehensive research? How do we encourage clearer, more timely guidance for people who are pregnant or breastfeeding? That's a really powerful question. It's not just about avoiding harm.
exactly. It's about ensuring everyone has equitable access to effective, evidence-based treatments when they need them, making sure all patients get the care they deserve based on solid data. Something to think about.